If you've ever wondered how medical devices actually get covered by insurance, you're not alone. Remember, there are three pieces to the reimbursement puzzle: coding, coverage, and payment. We've already talked about coding, so today we're going to talk about coverage, how payers like Medicare, Medicare Advantage, Medicaid, and private insurance decide whether to cover a medical device. Let's start with Medicare. And when I say Medicare, I mean traditional fee-for-service Medicare. It's run directly by the federal government through CMS, the Centers for Medicare and Medicaid Services. CMS decides if a device is reasonable and necessary and can issue a national coverage determination, or an NCD, that applies everywhere in the country. But if there's no NCD in place, which is actually pretty common, then the decision falls to local Medicare administrative contractors, or MACs. These contractors issue what's called a local coverage determination, or an LCD, which outlines whether and under what conditions a device is covered in their region. LCDs are based on medical evidence, local practice patterns, and clinical judgment, and they can vary from one part of the country to another. When there's an NCD and an LCD in place for the same therapy, the LCD cannot be more restrictive than the NCD, but it can be more specific. MACs are bound to the LCD if both an NCD and an LCD are in place. If there's no NCD or LCD, then MACs may make a decision on a claim-by-claim basis, which creates a lot of variability and uncertainty, especially for newer technologies. Now let's talk about Medicare Advantage. Medicare Advantage is technically still Medicare, but it's run by private insurance companies under contract with the federal government. So think of it as a hybrid: government funded, privately administered. These plans have to cover everything that traditional Medicare does, but they can set their own rules on things like prior authorization, step therapy, and utilization management. So even if a device is covered by traditional Medicare, a Medicare Advantage plan might say, sure, but only after you've tried something else first. Or they might require extra documentation or delay approval altogether. They look like private payers in how they behave, but they're still bound by Medicare regulations. And that creates a unique challenge for device companies, especially if your device is mostly used by seniors. Then there's Medicaid. Medicaid is different because it's a state-run program, even though it's federally funded. Because Medicaid is administered by individual states, there's no national standard. For instance, a device might be approved in Illinois, but take longer to get coverage in Georgia, simply due to different review timelines, budgets, or policy priorities, not necessarily because one state is more supportive than the other. Then there's private payers, like Aetna, Cigna, United, or Blue Cross. They create their own medical policies. They look at peer-reviewed studies, cost impact, expert guidelines, and whether a device is medically necessary. But they're not obligated to follow CMS's lead. Just because Medicare covers it doesn't mean they will. Now, let's touch again on coding and how it relates to coverage. Coverage cannot happen without a code. Talking CPT codes for procedures, HCPCS codes for devices, supplies, and ICD-10 codes for diagnoses. Remember, these codes are how your device gets recognized and billed in the healthcare system. Even if a device is FDA cleared and a payer wants to cover it, if there's no appropriate code, or if it's miscoded, the claim can get denied or stuck in limbo. For new, innovative devices, getting the right code can be just as big of a hurdle as getting coverage. Sometimes you have to start with a temporary or miscellaneous code while applying for a Category 1 CPT code or a new HCPCS Level 2 code. And that process can take years. It often involves public comment, review boards, and a strong body of clinical evidence. So here's the reality. Coverage and coding go hand in hand. Coverage says, yes, we'll pay for it under certain conditions. Coding says, here's how to bill for it. You need both to actually get paid and to make sure your technology is accessible to real patients. So now let's shift gears and talk about different types of devices because the coverage process is very different for an innovative breakthrough device compared to a Me Too product. Innovative devices, say a brand new brain simulator or non invasive cancer diagnostic, need strong clinical evidence to win coverage. Think randomized controlled trials, published data, real world outcomes. Medicare is trying to move faster with new initiatives like TSET, which helps promising devices get provisional coverage while more evidence is collected, but the bar is still high. In contrast, Me Too devices, those that are similar to something already on the market, often have a smoother path. If you can show your device is equivalent to another that's already covered, you might be able to leverage existing policies. It's a lot more straightforward, but it still requires documentation and strategy. So, what's the takeaway here? Getting a device FDA cleared is only part of the journey, just like we've talked about. The FDA says it's safe and effective, but payers want to know, is it worth paying for? Does it really improve outcomes? And will it replace something else or add cost? Coverage is about evidence, economics, and timing. And understanding how different payers make decisions is key to getting devices into patients' hands. Thanks for watching. Whether you're bringing a new device to market or just trying to understand how the system works, remember, coverage is where innovation meets the real world. And the sooner you start planning for it, the better. See you next time.